It's not something that people generally feel very comfortable. And for very many years, I try to avoid keeping this for postgraduate exams because the examiners themselves have problem making a diagnosis. So, but it's time that we brought this into the ambit of PG exams in pediatrics, so that I think children with neonatal cholestasis are managed or handled earlier than what they currently are. So the aim of this presentation may not be to answer questions in an exam, because questions that are asked are very different from what is the one in practice. So hopefully all of you who are listening will be able to approach neonatal cholestasis faster and better than what you currently do. As a means of introduction, I will just put up a few slides to explain to you what's the problem that we are dealing with. Now, what is cholestasis? Now, this is the simplest definition that you can come across for cholestasis. Impaired canalicular bile flow resulting in accumulation of bilirubin, bile acids, and cholesterol. Very simple. That means bile is not flowing through the canaliculi as usual, resulting in things that are excreted in the bile being held up in the liver and in the system. And what is it characterized by? Conjugated hyperbilirubinemia. Please note that when you say conjugated, it doesn't mean that everything is conjugated. No, this is a common misconception. If more than 20% of the bilirubin is conjugated, we say that is conjugated hyperbilirubinemia. More than 20%. The bilirubin is more than, total bilirubin is more than 5. More than 20%, if it's conjugated, then we say that's conjugated. It is not 80% or 100%. If the bilirubin is below 5, then anything more than 1 mg/%. This differentiation is made because practically in the technique of measuring bilirubin, direct bilirubin below 1 mg/% is not possible to estimate. The error is too large. That's why it is 1. So even if the total bilirubin is 3 and you get more than 1, then you say it is significant. So below 5, it doesn't depend on the number. Anything more than 1, because you can't estimate below 1. And more than 20%, it is more than 20% if the total bilirubin is more than 5. The 3 characteristics of cholestasis is jaundice, dark urine, and pale stool. So the first thing to make a diagnosis of cholestasis is to ask for the color of the stool and the color of the urine. Just to get all of you into the frame of mind of understanding what cholestasis is, this is a little congested slide, but don't worry about it. The liver is what is shown in that triangle. Uptake of bilirubin occurs from the plasma by the hepatocytes. It's an unconjugated form. In the blood, it is conjugated. It is in combination with albumin. If the albumin is low, bilirubin gets also bound with HDL, high density lipoprotein. That's the alternative. That's why some people who don't have, if you have a low albumin, you don't necessarily become jaundiced, because HDL then gets saturated with bilirubin. This gets taken up by the hepatocytes. It's conjugated in the hepatocytes, initially into mono and then into diconjugated bilirubin with glucuronic acid. Then is the step of excretion. This conjugated bile pigments or bilirubin is excreted into the bile canaliculi. This excretion is by 2 mechanisms. One is called bile acid dependent bile flow. That means the bilirubin will come only if the bile acid comes through. The other one is called bile acid independent bilirubin excretion, where even though the bile acid does not get excreted, bilirubin pigments will come through into the canaliculi. So this is important to understand, because different diseases involve 2 different mechanisms of involvement. Once they are excreted into the bile canaliculi, it flows through the small canaliculi and into the large canaliculi, and finally into the bile duct, into the gallbladder, and into the intestine. So when you say there is cholestasis, it means that there is a problem at one of these levels. Something beyond this is where the block is. That means it's either that the bile ducts are not well developed properly, or that they have got developed and then have got destroyed. That is what we call as a biliary atresia or bile duct hypoplasia or choledocalcis. They are all disorders of the biliary tree or the biliary system. Then you have disorders of the hepatocytes. That means they are the problem is here. The hepatocytes are not able to conjugate properly or partially conjugate and then excrete. So there could be a problem here at this level, or at the excretion level, or at the bilirubin, or at the bile flow, the canalicular level. So when you look at cholestasis, we are looking at a defect in one of these, and all the different causes of cholestasis are explained by this particular simple diagram that I have put up. So keep this in mind. There is conjugation, there is uptake, there is conjugation, mono and di, then there is excretion, and then there is bile flow into the intestine through the biliary tree. This is what it is. So anything that comes beyond this step is what we call as cholestasis. Keep this picture in mind. I'll come back to this later. So how do I look at neonatal cholestasis, the causes of neonatal cholestasis? I divide them into three. Obstructive, it means something is preventing the bile that is normally formed from coming through into the intestine. Or it's hepatocellular, it means that it's something to do with the conjugation and the excretion into the bile duct. Or extrahepatic, that means the defect is not in the liver, something that will but indirectly affect the liver from performing this conjugation and excretion. So what are the obstructive causes? The four most common obstructive causes are biliary atresia. Please remember that in biliary atresia, the bile ducts were formed, but they were not formed properly, or they got destroyed very early. So the formation of bile duct was defective, and whatever was formed got destroyed somewhere in pregnancy. Bile duct paucity is when bile ducts develop, but not enough bile ducts were formed. Then you have congenital bile duct anomalies, which involve the common bile duct or even the intrahepatic system, like choledocalcis or Caroli's disease, etc., where there is a structural problem with the bile duct. And last, there is this condition called progressive familial intrahepatic cholestasis, where there is a problem with the bile acid dependent bile flow. Remember, I told you there is a bile acid dependent excretion from the hepatocyte into the canaliculi and bile acid independent. So in progressive familial intrahepatic cholestasis, the bile acid dependent flow does not occur, and therefore there is retention of the materials. Hepatocellular causes, 4 again I have put. Metabolic causes, 3 I want you to remember that you will find a whole bucket of causes in the books. Forget all that. Remember galactosemia, tyrosinemia, and hemochromatosis. They are the commonest. Then we have neonatal hepatitis, idiopathic. We don't know the cause still. The percentage of neonatal hepatitis has been coming down over the last 20 years because we now are able to diagnose other conditions better. Congenital infection in very uncommon causes. Very rarely you can see this. It's cytomegalovirus infection. The other viruses don't. Herpes can cause cholestasis, but it is usually a very sick baby, and you will have already liver failure and not just a simple cholestasis that you are likely to see. Other causes of hepatocellular are related to total parental nutrition and inspissated bile, which I think are not very common. And the 2 extrahepatic causes I want you to remember are sepsis and hypothyroidism. So I've given you 10 causes which will cover practically 98% of all neonatal cholestasis. Now, if you want me to shorten this further to the even more common ones, remember biliary atresia and congenital bile duct anomalies. Among the hepatocellular, remember the 3 metabolic and neonatal hepatitis. And among the extrahepatic, both are important, sepsis and hypothyroidism. So 1, 2, 3, 4, 5, 6. These 6 are what I think any postgraduate or a pediatrician should look at, and they're very simple to differentiate. And at the end of this presentation, I'm hoping that you will all be able to do it. So when you are presenting, you're going to keep these 6 causes in mind as you present your case. Biliary atresia, congenital bile duct anomalies, metabolic causes, neonatal hepatitis, sepsis, and hypothyroidism. Okay, I'll stop at this point, and I think the presenter can take over. Yeah, please go ahead.
Good evening all, I'm Dr. Lekya from Apollo Children's. I'm going to deal with a history of this case presentation and followed by examination by Dr. Rini. Chief complaint, a 5-month-old male infant Rayan, a firstborn of non-consanguineous marriage, brought by mother from Bangladesh, whose availability is good, with a complaint of yellowish discoloration of eyes from first week of life and followed by passing pale color stool from 10 days of life. I'll start with history of presenting illness. Mother noticed a yellowish discoloration of eyes and body since first week of life. It was gradual and increasing in intensity and is also associated with pale stools, which is always persistent from since 10 days of life and also associated with dark urine staining diapers. And at 45 days of life, mother noticed abdominal distension, which is started after 3 months of age, is insidious in onset, progressive, not associated with pain, facial puffiness, or breathlessness. The child is not associated with fever, excessive cry, irritability, or refusal of feed, no history of any sleep disturbance, no history of seizure, no history of hematemesis or melena, no history of vomiting or altered bowel habits, no history of passing oily, bulky stool, no history of recurrent respiratory tract infection, and any bleeding from injection sites, or no history of blood transfusion. Antenatal history, the mother was booked and immunized, and no history of fever with rash or post-auricular swelling or joint pain or genital vesicle. She was diagnosed to have a gestational diabetes at 20 weeks of gestation, and she was on oral hypoglycemic drug, which was metformin. And history of jaundice was present 5 days prior to delivery, and history of pruritus was present in the mother. And no history of fever or foul smelling during the last stage of trimesters, and all the antenatal scans were normal. The child was born at 39 weeks with elective LSCA since mother is a short stature with a birth weight of 3 kg and baby cried immediately after birth, passed meconium in urine in first 24 hours and started the breastfeed from the day 1 of life, followed by there is no neonatal admissions and no history of any phototherapy or exchange transfusion. And umbilical cord fell on day 8. As per mother, there was no newborn screening was not done. After discharge, the child was continued on exclusive breastfeed and was on regular follow-up as advised by pediatrician. For the treatment course, initially the child was advised by the pediatrician, but the child got admitted in Bangladesh at 3.5 months of age. The investigations were followed, but further they transferred to the tertiary care center. Developmentally, there is no delay. The developmental age was appropriate. And for the immunization history, the child received until 45 days of immunization according to the local program. During each vaccine visit, the child weight was adequate. No history of excessive bleeding while on immunization. Nutrition history, till 3 months, the child received exclusively breastfeed. Currently, the child right now on breastfeed along with the formula feed and the vitamin supplements. Family history, no non-consanguineous marriage, firstborn of non-consanguineous marriage, no history of any abortion, no history of liver disease in family members. The family belonged to upper middle class. From my history, I would like to discuss is a 5-month-old infant of first born to non-consanguineous marriage with history of jaundice and pruritus in 3rd trimester. This child being a term with a birth weight of 3 kg with uneventful neonatal period. Presented with a history of yellowish discoloration of eyes and trunk from first week of life with the persistent pale color stool and urine staining a diaper since from 10 days of life with abdominal distension noted for the last few days. So with no developmental delay. I would like to discuss this case, a well child term appropriate weight for. The cholestasis jaundice was evidenced by high colored urine and persistent pale stool. So this is a neonatal cholestasis syndrome. Differential diagnosis from my history would be biliary atresia, are like choledochal cysts. Since it's a history, still I want to rule out some correctable causes so that I would consider metabolic. Since mother had a history of jaundice prior to delivery and pruritus, still I would consider a progressive familial intrahepatic cholestasis.
Okay. Thank you. Can you go back to your slide? Go back on your slides. Okay, this is basically a 5-month-old baby, isn't it? Go back.
Yes.
Yeah. 5-month-old baby, and the jaundice is from the first week of life.
Yes, sir.
Isn't it?
Yes, sir.
Was this conjugated or unconjugated at that time? What's the mother's blood group and what's the baby's blood group?
So both mother and baby blood group O positive, sir.
Okay, because there are very, very few causes other than metabolic causes where the conjugated jaundice starts within the first week. The dictum we follow is a conjugated bilirubin in the first week of life. First cause is sepsis, second cause is sepsis, third cause is sepsis, and fourth cause is hypothyroidism. Right? We don't look at primary hepatic causes when there is conjugated jaundice or direct bilirubin being high within the first 7 days of life. Most of the time what happens is it starts as an indirect, doesn't clear, and then it overlaps with a direct bilirubin. So always ask and present that to make sure that it was not an indirect. I suspect this was an indirect hyperbilirubinemia, right, which later became conjugated. Next slide. Next slide. Okay, next slide. Right. This abdominal distension is only from 3.5 months of age, is it?
Yes, sir.
Okay, right. So that means the jaundice is coming so very early, and the whatever your organomegaly is coming only at 3 months of age. You're sure about this pale colored stools from day 10?
Yes, sir. The child got discharged at 3 days after birth, since mother is elective LSCS. And then mother noticed the jaundice and they reviewed with the pediatrician. They were told that it is not in the phototherapy range, so the child did not receive phototherapy, sir. And then completely
that means
the child...
it was indirect at that time. That's precisely what I'm trying to say. Yes, it must have been an indirect hyperbilirubinemia. But remember this. A jaundice in the first week, cholestatic jaundice, please remember sepsis as the first and second cause and hypothyroidism as your next cause, right? Don't look at primary liver disorders at that stage at all. And a pale stool noting from day 10 is also a little funny because even if you have a biliary atresia or you have bile duct anomalies, all that, the pale stool comes a little later on. I suspect this mother has been asked repeatedly, and now she's got tuned to saying that it's 10 days or 12 days. So normally they notice it only a little late. She's a primigravida?
Yes, sir. She's a primigravida.
All the more reason why she would not have picked up a pale stool, because she would not have known what a normal color stool is. So it's, I think, retrospectively a data. Next slide. Okay, tell me why you asked all this negative history. No history of fever, excessive cry, irritability and refusal of feed. What were you asking for?
Sir, history of fever to rule out sepsis.
Can it go on from 10 days till 5 months? Not possible. Right? And, maybe you won't survive. So this, at 5 months of age, that sepsis starting from newborn period is irrelevant. Yes? Right. No history of sleep disturbance or change in interaction with mother for what?
Sir, in view of encephalopathy, if
encephalopathy 5 months.
Sick child.
Is this a sick child?
No, sir.
No, a well child. Yeah, not significant. I think you must tailor to the cause here. Here, something is going on for up to 5 months of age. So we are not looking at a sick baby. This is a well baby who's got a cold problem, something that is, going on for quite some time. So I would not put all that. See, I gave you those 6-7 causes in my list. Your negative history should be tailored towards that.
Okay, sir.
Understood? It cannot be an aimless negative history. Undergraduate, it's all right. At a postgraduate level, the negative history should be relevant. You must have this diagnosis in mind, and therefore you ask a negative history. You don't get any credit for giving an aimless negative history. It must be a focus. No history of seizures. What were you thinking of?
So metabolic causes like galactosemia, which causes
Galactosemia. I accept that. So galactosemia is a possibility. So you thought of seizures.
Yes, sir.
Okay, right. What else?
History of no history of hematomysis in coagulopathy or vitamin K deficiency.
Okay, right.
And no history of vomiting in the sense like even in galactosemia, they'll present with vomiting and thyrocinema metabolic causes. Altered bowel
in a baby with galactosemia, there will be failure to thrive and the liver will fail. That's a manifestation of a liver failure in galactosemia. Yes. And I don't expect a baby with galactosemia with very early onset jaundice due to a galactosemia to be well at 5 months of age. You understand? That means the enzyme deficiency is almost total. Only then they will present you with cholestatic jaundice by day 10. Our problem here is that cholestatic jaundice of very, very early onset.
Yes, sir.
Understood? It's not like any other cholestasis. You have to explain or look for a cause where your cholestatic jaundice is starting within the first 2-3 weeks. But the baby is well even at 5 months. Understood? So your tyrosinemia, hemochromatosis, galactosemia, all that is very unlikely in this situation. Yes. We think of that in an appropriate setting. So in this particular patient, I would think all that is extremely unlikely. Yes? No history of passing oily, bulky stools. Why?
So steatorrhea will be expected in cystic fibrosis.
Right. Pancreatic insufficiency as a manifestation of cystic fibrosis along with a liver involvement is extremely rare. Most of the time in cystic fibrosis, you either have a respiratory involvement or a pancreatic involvement as early manifestation, right? And they have severe failure to thrive, severe failure to thrive. So if you have a child with a cholestatic jaundice and failure to thrive, then oily, bulky stools and all that become important, respiratory manifestations, etc. That means the liver is involved as part of that. But here again, I'm stressing, your problem in this particular patient is that the jaundice is starting within 2 weeks.
Yes, sir.
Right? That's your problem. This is a very early onset cholestatic jaundice, which is leading to a well baby at 5 months. And you have not given me anything to suggest a liver failure in your history at all. That means early onset cholestasis, which has not led to liver failure at 5 months from your history. No history of recurrent respiratory tract infection for cystic fibrosis?
Yes, sir.
Very, very rare. Please take off cystic fibrosis from your dictionary for cholestatic jaundice. That's yes, common in Western countries, and they all present much later on. They don't present in the first few weeks of life. And it's usually what we have found is bile duct strictures and those sort of things, not in our garden variety of cholestatic jaundice. No history of bleeding from injection sites, I would have put up very high. I would have put that up very, very high because the commonest manifestation of cholestatic jaundice in our country is bleeding from injection sites or from minimal trauma. Yes. So that should come way above all that. Yes? No history of blood transfusion. Why?
Sir, through the blood transfusion, we get a viral hepatitis, so that lead to neonatal hepatitis. So
when could it be? If you have to, what's the incubation period for hepatitis B?
Sir, it's late, more than 30 days, sir.
So it cannot be. So you want to withdraw that sentence?
Yes, sir.
If I let you withdraw it, you will withdraw it. Your problem, I told you again, is that the jaundice is starting from day 14, right? What I was wanting to bring up is to say that make your negative history relevant. Like I said, we are focusing on a child. What's the problem we are discussing? A 5-month-old baby with extremely early onset cholestatic jaundice, who has no failure to thrive and no liver failure at 5 months of age. A very well preserved, something that is going on very slowly, a gradually progressing condition over 5 months, which has still not affected the baby in any manner, has not caused liver failure, has not caused a delay in the somatic growth. Yes?
Yes, sir.
Right. Go on to your next slide.
If I may interrupt, I think
Yes.
Ilakya mentioned something about mother having pruritus.
That she's coming to that. She will come to that, I think. That's on the next slides, I think. Yeah, there, here it is.
Yes, sir.
Yeah, that is here. Yes. Now you can tell us in this, in the antenatal, what's important. Yes, tell us.
So significantly, mother had no history of fever with rash, post-auricular swelling, or joint pain, or genital vesicle.
Why were you thinking of?
Intrauterine infections like rubella, herpes.
I told you the only one that is significant is cytomegalovirus. And herpes will cause neonatal liver failure. If you pick up neonatal herpes, it's liver failure. It's a differential for liver failure. Understand? They won't survive till 5 months of age with a neonatal herpes infection. So I'm not too bothered about that. But like what Dr. Shamla said, let's look at this jaundice and whatever. Why don't you tell us something more about it?
Yes, sir. Mother presented with a jaundice 5 days prior to the delivery, and she associated with pruritus.
Okay. Anything more you want to tell me about that?
Sir, in this time we can predict like cholestasis of pregnancy, sir.
So the mother could have had cholestasis of pregnancy. In which case, what will be the characteristic of that pruritus? It will be unresponsive to antihistamines. Unresponsive. That's the key. It's unresponsive to antihistamines or whatever they give you. Second, what's the second characteristic?
So it will be very intense.
That is very okay. What more? That it remits after the baby is delivered. Understood? So it's an intense itching which is unresponsive to antihistamines, what they normally give for itching. And second, it remits after the baby is born. So did that happen, or you didn't ask the history?
No, sir. After the child born, there is no evidence of jaundice or pruritus, sir.
In the mother. So that's a history that you have to tell me. Only then you make it as a cholestasis in pregnancy. That it relieved once the baby was out. Yes?
Yes, sir.
Anything else? Otherwise, Sumati and Dr.
Yes, sir.
Do you want to ask any questions?
So, Ilakya actually is okay, good presentation. But the first slide, you said the jaundice at first week of life. Though, as sir said, it's very early. Next question, you should focus on the urine color. Because a single urine color, if you ask a mother, if she says, yes, she stains a diaper, that says if the jaundice is pathological. Because you don't get staining of the diaper in unconjugated hyperbilirubinemia, as you see in your physiological jaundice, ABO, RH, whatever it is. Because conjugated bilirubin is water soluble, gets excreted in the kidney. So that is always a pathological. Then you should, so once you say there is jaundice with high colored urine, there is cholestasis. It can be, as sir said, due to hepatocellular or obstructive causes. So that there comes a stool color. The stool is the one which is going to tell whether it is hepatocellular or obstructive jaundice due to biliary atresia. But the word adjective is persistently pale stools. If persistent pale stools indicate there is obstructive cholestasis unless proved otherwise. You can even get transient pale color stools, even hepatocellular cholestasis. So the first history is jaundice, second is urine color, and third is the stool color. And the stool asks whether it is persistently pale or clay colored or even dirty butter like. So you can think possibly biliary atresia. Okay, but as sir said, very early onset, very rarely you can have in utero onset biliary atresia, but usually the cutoff of 14 days is given because most of the jaundice is physiological. But the urine color is the one which is going to segregate whether it is physiological versus pathological. That history is very, very important. Second, as sir said, you said no, there is poor feeding, vomiting can be due to
metabolic causes like
so because stool is it is pale, persistently pale. So if you feel it is biliary atresia, the vomiting, seizures, poor feeding can be due to IC bleed. Most important lethal complication of cholestatic jaundice is always the coagulopathy clinically manifesting is IC bleed. So a child can suddenly become pale. The mother can bring the child who is not taking feeding well, he or she, and vomiting. And if you just put your finger on the AF, if there is bulging AF, always keep an IC bleed. And third, also your intramuscular bleeds or any bleeding from the intramuscular site or a vaccination site. That is very important. So when I say, even you can sometimes the mother can give the history of prolonged bleeding from the umbilical stump. You always think it is due to factor 13 deficiency, but if they ask the mother, if the urine is high colored, keep cholestatic jaundice with coagulopathy presenting as umbilical bleeding from the umbilical stump. Okay. Then after 16 weeks or 5th month, the child can have incessant cry, irritability due to itching.
Itching.
Once a hand coordination is obtained, the child can even pull the earlobe. The child can have irritability, poor feeding, and not sleeping well, disturbances. That can be part of a pruritus. But well-established pruritus with all the itch marks, shiny nails, hyperpigmented skin will occur after the 6th month or even later. As sir said, steatorrhea usually at this age is very, very uncommon, but very rarely cystic fibrosis, but more common the best. You keep down the list, but not high on the list in our population. So sick child or a thriving child, that is very important. Once you feel it is biliary atresia, usually the dictum, they are well, a thriving child, they gain weight properly, they don't go for any sickness, unlike your galactosemia, tyrosinemia, or your mitochondria, whatever it is, hepatopathies, and other metabolic liver disease. So that is very, very important. And as far as a recurrent respiratory tract infection are more common in your cystic fibrosis, which you rarely see. When the examiner asks you what next, then you can bring it up. Always a common thing. And if you are committed blood transfusion, you should know how to escape. You can say, I see bleed, child become anemic. Even after FFP transfusion, if the hemoglobin is very low, you can give blood transfusion, but not for B and C in general. Okay. The mother has jaundice during pregnancy, especially during the last trimester. During the viremic phase, she can transmit very rarely A and E because A and E is a fecal transmission. B and C can be transmitted via your vertical transmission, but presenting as neonatal cholestasis is very, very rare. 1 or 2 cases, very rare, but don't bring all those things. When they ask you, tell what is the purpose of it, not as a routine thing. Okay. And next slide, please. And apart from the pruritus, the mother, as sir said, you can think of some of the PFIC, even acute fatty liver in pregnancy. If she has a documented history, L-SHA deficiency, long chain acyl-CoA deficiency can have present with neonatal cholestasis. And apart from that, IUI infections, the first trimester is very, very important. Jaundice, the mother asked, very important. And antenatal scans. What is the importance of antenatal scan? Any idea on that?
Ma'am, we can find us even the choledochal cyst in the antenatally, ma'am, and or in the embryonic state of biliary atresia.
How? What is B? See, biliary atresia to diagnose as such is very difficult because there will not be any intrahepatic radical dilatation. Do you have any indirect evidence? What is BASM?
Ma'am, biliary atresia, so splenic malformation.
Malformations, okay. You get either accessory spleen, polysplenia, citus inversus, or indirect evidence.
Midline liver.
Midline liver, whatever it is. Diagnosing biliary atresia as such is very difficult, but you have any accessories or whatever it is, the confounding evidence of biliary atresia, you can think about that. Well, choledochal cyst you can diagnose to some extent, yeah. And fetal gallstones, usually they are asymptomatic. Okay, so don't commit unless a stone passes and absolutely common bile duct. It's very, very unless. Yes. Next slide.
I have a question. Dr. Ilakia, you mentioned that mother had noticed pale stool from 10 days.
Yes,
Dr. Matai was mentioning that as a primary, she may not have realized the significance. Do you think she brought it to the notice of the doctor, or the doctor did not ask, or what happened?
She was brought to the notice of doctors, but by the time it since 10 days of life, doctors were counseled the mother. It could be the normal thing. We can wait over it, ma'am.
No, but she has been attending the hospital for regular vaccinations, right?
Regular vaccination, and they were visited like multiple doctors and delayed their diagnosis, ma'am.
No, but was the jaundice picked up during the vaccination visits or not?
Yes, ma'am. It was picked up during the vaccination visit itself, ma'am. Second visit of vaccination.
Nothing was done about it,
ma'am.
Nothing was done about it. I mean, if there was jaundice during the vaccination.
Since the child is like initially the child, the infant is like well thriving with apart from this jaundice and this one, so they were counseled. If it is even persisting, they asked them to come back, but parents were didn't get back to them.
Okay, I think something was missed at that time, because surely the doctor must have picked up jaundice, and doctor must have not done tests, or I don't know, during a busy clinic, maybe something was missed. The other question is, you mentioned about screening. What is the relevance of screening?
Ma'am, usually now we are starting newborn screening. We can able to find this common metabolic causes like galactosemia, thyroxinemia, cystic fibrosis, congenital hyperthyroidism.
Okay. So anyway, you don't think there was, you think it is clearly cholestatic. So any of those causes might still be associated with the
Yes,
not,
ma'am.
right. None of these causes would have been,
Yes, ma'am.
yeah, missed, right. Okay.
Okay. I have a question. I think this is more for whoever is watching the show. What's the average presentation of neonatal cholestasis in this country? I just want to know from your guess, what's the average? All the studies, all of us have put our data together. What would you, we are all blaming the Bangladeshi pediatricians. I'm not sure the Indian pediatricians are any better. 20 years ago, it was 91 days, right? After that, a big yellow alert campaign and conferences and CMEs have all been held. 12 years later, in 2012, when we put the data together again, it was 87 days. So that's all the difference that we made in 12 years of all the CMEs and programs. So I still think it's around 80 to 90 days. Most of the cholestatic, there is a significant delay in diagnosis of cholestatic jaundice in this country. And I hope the CMA will address that issue. So what are the common mistakes that occur in this early diagnosis? Or why does early diagnosis not occur? What are the reasons?
So most of the time, pediatrician in the first few weeks, if the child presents with
the question myself, because you will otherwise embarrass the pediatricians. So I'll answer it myself. The commonest reason is people do a bilirubin, but only look at the total bilirubin. They don't bother it's a direct or indirect. That's the commonest, right? Everybody, even from the newborn period, I have seen so many cases, conjugated will be high, but nobody looks at it. People will only look at the total bilirubin. That's the number one cause. Second, mothers and doctors don't know what is a pale stool. Really, because doctors are worse, right? Yellow has different shades. It's a huge shade. No other color has so many shades. My wife and I have never agreed on what is yellow because everything is yellow to me. For her, something is different. So, and when you ask, that's why I'm very surprised a Bangladeshi mother picked up a pale stool at 10 days. It's extremely difficult. Our doctor mothers themselves don't pick up, right? Because nobody knows, particularly if it's a primigravida, they don't know what a normal stool is. When we say golden yellow stool, that's all for theory. That's a second reason. Doctors and mothers not knowing what a pale stool is. Third is, really, all babies are now examined where inside the consultation room of doctors in artificial light. And you cannot pick up jaundice in artificial light. You need natural light. You need to take a baby out into the sunlight to see jaundice. You can't assess jaundice in artificial light. This is the commonest reason why doctors miss jaundice, because nobody has access to direct sunlight now. Everybody has only fantastic lights inside their room, so you can't pick up jaundice. That's the third. So you maybe when you start a practice, you please have a window with some sunlight. Fourth cause, what I have found is bleeding after vaccination. What people do is to put ice on top of it or sit on, press it, do all sorts of things without thinking of either a bleeding disorder or a liver disease. Bleeding after vaccination is pathological. Don't try to treat it. Find out why they bled. You are not likely to go and hit a vessel when you give into the thigh. So very, very common. Repeatedly, I have found this. So if a child with a pediatrician or anybody, a nurse vaccinates a child and the child has bled from the vaccination site, it should not be ignored. Fourth is babies have abdominal distension, but nobody likes to palpate the abdomen. No baby has an abdominal palpation done. They have ultrasounds done before an abdominal palpation. Everybody likes to stethoscope and auscultate the chest and the back, and if possible, the abdomen also. Your hands are more sensitive than ultrasound probes. So doctors, if you can put your hand on the abdomen and palpate a baby whose mother says, mother, baby has got abdominal distension, or you think the baby's abdomen is distended, we could pick up liver disease and cholestatic jaundice earlier. So these are the common mistakes that occur in cholestatic jaundice, which is what leads to delayed diagnosis. This is why we are now stressing on urine color rather than a stool color. I will put up a slide and I will put up a picture and show you why it's easier for a mother to pick up a high colored urine rather than a pale colored stool. Right? I will put that up later and show you what it essentially means. And all pediatricians should ask for staining diaper with urine rather than a pale stool, because it's practically very difficult. Can you proceed? Yes, go ahead with your next presentation. Yeah, finish and go on to the examination.
Yes, sir. So on examination of the child was conscious, alert, icterus was noted till abdomen. The child was not pale, there was no cyanosis, clubbing or lymphadenopathy, and there was no dependent edema. Examination of it, there was no microcephaly. Anterior fontanelle was flat, 3 + 2 cm. Posterior fontanelle was closed. There was no dysmorphic facies. The child had no cataract. There was no bruising or ecchymosis, no pruritic marks. Limbs were normal. There was no signs of vitamin deficiencies or any liver cell failures. Vitals, heart rate was 124 per minute, was regular normal volume. There was no specific character felt equally. BP, the child was normotensive. Respiratory rate was 36 per minute. Was normothermic and saturations were normal. Anthropometry, weight was 5.5, came in third centile. Length was 58 centimeter, was less than third centile. Head circumference was 45 centimeter, it came in 97th centile. Weight for length was the third to 50th centile. These are the chart, IAP charts. So, systemic examination, I would like to start with the abdomen. The oral cavity was
IAP chart, or is it some Acta Pediatrica supplementa that you have put up there?
No, sir, IAP only, sir.
IAP only?
Sir.
WHO.
Because if a baby is 3
was WHO chart.
yeah,
WHO.
that's a WHO chart.
WHO chart.
That's right. Don't make these mistakes. Right. Yes, go ahead. So there is some bit of retardation in weight and
Yes, sir.
length. Length not too much, weight, but you think the feeding is adequate?
The mother has said that she had reduced breast milk supply. So at 3 months of age, she started on formula feeds.
No, our clue here is we have to decide whether this is because of the liver disease or is this because of inadequate feeding. What do you think?
Probably feeding, sir. Otherwise, the baby is active, developmentally normal child.
No. These two different things. Developmentally normal has got nothing. You can be underweight and still be developmentally normal. So your assumption is that
but
this is
length is also affected.
No, I'm asking you a question. You have not given me an answer. You are giving me something else. Do you think this under the somatic growth retardation is because of the liver disease or because of feeding inadequacy? What is your impression?
Probably liver disease, sir, because it's chronic.
I accept it. I have no qualms with you. I'm only asking you to commit. So you think it could be because of the liver disease? Accept it. Yes. Right.
On examination of abdomen, inspection, upper abdomen is distended. All quadrants are symmetrical, moves equally with respiration. Flanks are free. Umbilicus is normal, inverted and pushed down. No visible pulsations or peristalsis seen. No skin over the abdomen is normal. There's no scar or sinuses. Thin veins are visible in the anterior abdomen walls. On palpation, superficial palpation, abdomen was soft. There was no tenderness, guarding or rigidity. On depalpation, liver was palpable, 4 cm below the right costal margin. Was regular with rounded margins, smooth surface, firm in consistency. Spleen was palpable, 2 cm below the left costal margin along the splenic axis, firm with smooth surface. On percussion, liver span was 8 cm. There was no shifting dullness. On auscultation, there was no bruit. Bowel sounds were heard and normal. External genitalia, bilateral testis descended and is palpable in scrotum. Hernial orifices were free. And examination of stools, it was pale. And examination of urine was dark yellow. Other system examination, cardiovascular system, S1, S2 heard and was normal. There was no murmur heard. Respiratory system was normal. CNS, child was conscious. Anterior fontanelle was flat, and there was no focal neurological deficit. Musculoskeletal system was also normal, sir.
So, on summary, this is a 5-month-old male infant, a well-born baby to non-consanguineous parents with no significant perinatal and neonatal events, with complaints of prolonged jaundice, persistent pale color.
No significant perinatal event when the mother had jaundice.
Mother
And
had jaundice.
you are not thinking. This is a significant perinatal event. Yes.
With complaints of prolonged jaundice, persistent pale colored stools and high colored urine with hepatosplenomegaly with no signs of liver cell failure on examination, with other systems are normal. This is a case of neonatal cholestasis syndrome. I would like to.
No, we'll stop at this point. Just go back to where you started. It's a very good presentation. This is what happens when you get 1 week to prepare. In an exam, you get only 45 minutes. This is why I always say give case 1 hour earlier. This is all 3 nights you have not slept, I think. Preparing this detailed. I have been, listening to exam presentation for the last 25 years. I've never had such a presentation because in 45 minutes you can't do all this. Focus on the essential things. Okay, that's a difference between an undergraduate and a postgraduate presentation. Right? At a PG presentation, you are more focused. You are not complete. You are more focused. A UG presentation, we look at a complete presentation. PG presentation is a focused presentation. Yes. Child is conscious, alert, icterus noted till abdomen means what?
The skin till the skin of abdomen.
Importance is only for newborn babies with hemolytic jaundice, with unconjugated hyperbilirubinemia. Please take that sentence out and don't use it for the rest of your life. It has no significance at all. Only for unconjugated hyperbilirubinemia in a newborn to assess the severity of the jaundice. Instead of doing blood, you can do this, extend to the leg and all that. Neonatologists will tell you, I always found it very difficult. And after that, the skin becomes thick. Once the skin becomes thick, later you cannot really use that. No pallor, cyanosis. Why clubbing there? All of you are very fond of clubbing. What liver disease will give you clubbing by 5 months? What liver disease will give you generalized lymphadenopathy? This is just a routinely written there, not significant. What am I interested in here? What will be more icterus, then skin bleeds, scratch marks. Those are more important in your general examination. Focus again. This is like a general, no pallor, clubbing, cyanosis, lymphadenopathy. It shouldn't be like that. Focus. Itching, icterus, skin bleeds, and these are the 3 things that we are focusing on general examination. Anything else that you would like to know if you have a baby with cholestatic jaundice? What other vitamin deficiency can you get?
Vitamin A, sir.
A, generally we don't get deficiency signs before 5 months. You can get it with vitamin D deficiency. Vitamin D deficiency. Okay. So that's something that I would look at in that. You said anterior head is no microcephaly. You must tell us the head circumference. Somewhere later you have said this.
There's a 45 centimeters.
Say that there. Head circumference is 45. Yes. All right. I think the parameters are reasonably all right. I'm not too worried about it. Yes. Next slide. Yeah. No dysmorphic facies. What were you looking at?
Sir, in case of Down's Allegheny syndrome.
Downs or Allegeels? You have to tell me one.
Sir, Allegheny is more common.
Allegeel syndrome. Okay. Have you seen Allegeels?
No, sir.
It's quite rare. It's not very common at all. Yes. No cataract. Why?
So in galactosemia, we can get
galactosemia. No bruises, no ecchymosis. Yes. Fine.
deficiency.
Yeah. See, don't put your significant negative history submerged inside a whole basket of irrelevant negative history, negative findings. Understood? Like I said, your bruises, ecchymosis, pruritus and all should come way above your dysmorphic facies, etc. Right? This child has no ecchymotic patches from the bleeding site, from IV sites or anything, wherever they have poked.
No, sir.
No. Limbs are normal. Why limbs are normal?
Sir, this is for Agnew syndrome.
Please leave all that. There are 100 causes of cholestatic jaundice. I gave you 10 causes and brought it down to 6 or 7. In your dictionary, there are only those 6 or 7. Don't think of all Jaundice syndrome, and there are hundreds of, it's all not important for you. Just remember the 10 or at least the 7. 98% of cholestatic jaundice will come under that. Agenese syndrome and all will present. There are patients who have Agenese syndrome who, if you look at the bilirubin, will be high. They don't present you with cholestatic jaundice. None of them. All those rare syndromes are not causes of cholestatic jaundice. They don't present you with jaundice. It's not the presentation. No sign of vitamin deficiency. I want to know what you looked at. That's a blanket statement. What is it that you looked at? You are looking at vitamin A.
Yes,
You looked at vitamin A.
Bite spot, but
Did
it's
you look?
cornea xerosis.
You have to tell me all that. You have to look at corneal xerosis. See, this baby is 5 months. So that's about the earliest that you can get vitamin A deficiency in a baby with severe cholestasis, by 3 to 5 months. Intrauterine stores of vitamin A are sufficient for the first 3 to 5 months. Right? So unless you have severe cholestasis, you don't get it. So, but you must look and say that you look for vitamin A deficiency sign. Vitamin D you can get earlier than that. So you should look at anti-fontanelle and things like that. Right? E you can not get at this age. How does vitamin E deficiency present?
Subconjunctival hemorrhage.
Vitamin E.
Bleeding manifestations from the.
That's quite late. Before that, you can get hemolytic jaundice, hemolysis, or your ankle jerk will be very difficult to elicit. Depressed ankle jerk. Very difficult to make out in our babies. So don't look at that. But those are the earliest vitamin E deficiency signs that you can get. Your knee jerk and ankle jerk are difficult. Normally, it's very brisk in small babies. Here, you will find that it is difficult to elicit. No signs of liver failure. What were you looking at?
Sorry, usually in spider navy and palmarentima, but in young babies, it won't be there.
I don't want this but. I want a specific answer. You don't get spider nevus and all at this age. Be very specific what you looked at. If you are looking at ascites or you're looking at abdominal distension, distended weight, be specific. This is a very blanket statement. No signs of liver failure. Be very specific. Right? This is the vitamin deficiency I looked at. These are the signs that I looked at. Yes, next slide. Yes, all right. Nothing very much. You can't do SpO2 and temperature and all in the exam, so you can forget it. This pulse rate also, this whole big line is important only if it's a cardiovascular case. Not for liver who is interested in character and all. That all makes nice reading. But practically it has no relevance. Yes, right. Next slide. We said all right, head circumference is all right. Weight and length, I'm not too bothered about as long as it's above third centile. Yes, they're from a developing country. Third centile is quite all right. 5.5 to me with a birth weight of 3 kilos, I'm quite fine with it. I still go by the old dictum of double your birth weight at 5 months. So at 3 kilos, 6 kilo is what is expected. 5.5. Having traveled all the way from Bangladesh to that itself would have lost 1 kilo. So I'm not too bothered. So this baby is well preserved. It's a well preserved baby. Brain growth is normal. So whatever is the disease, it really has not affected the brain growth at all. So it's none of those multi-system disorders. That's what I was trying to say. Next slide. Okay, next. Yes, oral cavity. What did you look in the oral cavity? No, nothing. All that is not significant. Upper abdomen distance. What is there in your system examination? No scar. This is all pre-prepared text that you have filled up. In an exam, you will not get time to do all this. You want to know whether the abdomen was distended or not distended. Whether there were any visible veins or dilated veins. Visible veins are normal. It only means that the skin is thin. Dilated veins are significant because it means there is obstruction. So use that word very carefully. Visible veins versus dilated veins. So distended abdomen and dilated veins or visible veins. Right? Next, all quadrants and all will move. For liver disease, all quadrants will move. Yes. Now, liver is a superficial palpation or a deep palpation? Liver is a superficial organ or a deep organ?
Superficial.
Liver is just underneath the skin. If you go and palpate deep, you will go and hit the kidney and pancreas and all that. And this is the commonest reason why liver is missed on palpation. Understood? Unfortunately, this is an online session, so I can't show you. But the big problem we have is that people don't know how to palpate. liver. I can't demonstrate how to do it, but you must, it's a superficial palpation, right? Superficial, because the liver is just underneath the skin. So don't do, this is a cardinal mistake. It's not a deep palpation. Deep palpation is for kidney and something else. Understood? Don't press the abdomen too much. You will miss the liver. You have gone beyond the liver. The same thing for a spleen. Your anatomy, you'll remember. Liver and spleen are both right underneath the superficial structure. Yes. Liver is 4 centimeters below the right costal margin. Yes. Where? In the mid-clavicular line or midline?
Mid-clavicular line.
You have to say that. Mid-clavicular line denotes the right lobe. Midline is the
Left lobe.
left. There are only two. That's it. So I need to know that whether it was right or was it the left, which is enlarged. Regular. What do you mean? Regular means what?
If there's nodular, it will be regular.
Then you have to say smooth surface. Surface is smooth. When you talk about the liver, you talk about, say, liver is palpable so many centimeters below the right costal margin, in the midline, so many centimeters in the mid-clavicular line, both. The liver is soft or firm or hard. Surface is smooth or irregular. Edges are sharp or rounded. Upper border is in such and such a space. Liver span is so many centimeters. All this must come in your presentation of the liver. You want me to repeat it once more? Liver is palpable so many centimeters below the right costal margin in the mid-clavicular line, so many centimeters in the midline. Liver is smooth, surface is regular, edges are sharp or rounded, upper border is in such and such a space, liver span is so many centimeters. Each of these findings has a significance, right? Yes. Surface is smooth. You said rounded margin and firm consistency. They are oxymorons. It doesn't go together. If you have a rounded margin, a firm liver, the margin cannot be rounded. The margin will be firm. Margin will be sharp. You understand? When you say liver is firm, it means it's easy to get. You put there, it's there. You can't have a rounded margin. Basically means that it's not that the liver margin is rounded, if you remember your anatomy. It is just that it is so soft that I can't get an edge. Understood? It's not that it becomes round, that it's so soft that I can't get an edge. So our forefathers called it rounded, not that it became rounded. But once the liver becomes firm, it is easy to palpate, the edge will be sharp. Right. So here you said rounded margin, spleen is this thing, and spleen is firm. You want to withdraw that? I think the spleen will be soft. Very unlikely that by now the spleen would have become very firm with the liver so well preserved. In this situation, your spleen will only be secondary to portal hypertension. It means there must be cirrhosis. It means the liver must be shrunken. So that's a wrong finding. I'm not sure that is correct at all. Right? Next slide. Liver span is 8. Okay. No shifting dullness. So no fluid at all.
Yes.
Right. Relook at that spleen once more. I'm not sure that's correct at all. Yes. Right. Next slide. Yes, this is a pale stool. Right. Perfect. Urine.
Urine was yellow, sir.
Dark.
I think I would have wanted a picture of that. To all those who are listening, that's what I want to focus. To say that, please look at. I will put up and show you what urine staining is. But focus on the urine. All postgraduates, all mothers, all doctors. Yes, next. This is okay. Cardiovascular system, yes, nothing much in that. So essentially, it's a unisystem involvement. A disease that is involving the liver, early onset, slow progression, and at 5 months has not affected the baby's growth and has not affected the liver function. The liver is functioning normally, baby is growing normally, but the jaundice is gradually something very, very slowly progressing disease is what we are looking at. Most of those causes that I put up, it will be progressing more rapidly, isn't it? Whether it's a biliary atresia, neonatal hepatitis, metabolic, all those I would have expected it to progress more. So I already have a diagnosis. This, I think, did not need this presentation. After your third slide, we could have made a diagnosis, right? I think you should have kept that bit of information for later on. You didn't, that bit really gave away the whole thing. Yes. Sumati, you want to ask anything, Dr. Shamla?
Skin, apart from here, ecchymotic patch, intramuscular hematomas, petechiae purpura, IUA infections, blueberry muffin. What is blueberry muffin, Ilakya?
Extramedullary hematopoiesis.
Extramedullary hematopoiesis, otherwise a dermal erythropoiesis, which is more commonly seen in intrauterine infections. Okay, so that you can just bring it if it is no, because no negative points, you can just no blueberry muffin. That is very important. Dysmorphic, allegedly. Intrauterine infections will can have congenital hypothyroidism, will have dysmorphic facies. Your downs will have dysmorphic facies. So keep that. And the third thing, like your umbilical hernia.
Yes,
It can be due to thyroidism, hypothyroidism, or Down syndrome, or due to ascites, due to increased intra-abdominal pressure. So that important is you can tell if it is there or not. Okay. Then you said liver is palpable. So in children, the consistency is very important. The firmness indicates what? It's an acute or chronic? Chronic liver disease. In biliary atresia, what happens to liver?
Firm.
Usually, it is
firm, ma'am.
It is firm, large, unlike your neural hepatitis, where the liver will be soft. Usually, unless it has gone for cirrhosis. And spleen will be early in
neonatal hepatitis, ma'am.
And as sir said, spleen indicates what in biliary atresia?
Portal hypertension.
Portal hypertension. So that is very important. So look for any ascites if possible. Look for any veins. Okay. Pre-cycle edema, because it's a dependent edema in children, young infant, very, very difficult. Pre-cycle edema, abdominal fluid, whatever it is, indicates what? Liver cell failure. Okay. Next slide. Okay. Why violated testes? Descended. What are the causes? Anything to do with that?
Ma'am, in perforated bile duct syndrome.
What happens perforated bile duct syndrome? What you see about what the color of the scrotum? Will you think this 5-month-old child? You get ascites, green scrotum. Okay. And if you just do acidic fluid, what? You can diagnose it by simple investigations.
Bilirubin will be high.
Okay, bilirubin in the acidic fluid, but not bilateral testis descendant can be seen. Why? Hypothyroidism, Down syndrome, can have undescended testes. Your midline defect, pan-hypopituitarism.
Yes, ma'am.
Sir was asking what is the importance of your oral cavity. Usually, if it is there any cleft lip or cleft palate is, I think, midline defect.
Okay.
Very, very rare. Okay. So testis, if you make sure pilot testis descendant means what is the reason you are looking for that? Okay.
Yes, ma'am.
Yeah, next slide. Okay, next. Okay. Okay, next. And so whenever you see a child with jaundice, the important clinical clue to say there's pathologic jaundice, your liver and spleen.
Yes,
a jaundice with hepatomegaly, a jaundice splenomegaly is always pathological. So by history, urine color is very important, pathological. Stool color is very important, then organomegaly. When you see jaundice with liver and spleen, it is always pathological. You don't get liver and spleen in physiological jaundice. Okay. A small spleen may be normal in newborn. I'm not telling that, but 4 centimeter liver, a firm liver with jaundice, it is not physiological. Next, yeah. Okay. So once again, it's a broad terminology, neonatal cholestasis syndrome, but the likely diagnosis is what you're suspecting in this case.
This case, since it's a well-thriving child with persistent pale-colored stools and high-colored urine, I would first like to rule out a biliary atresia in this case.
Yes, why?
Because the baby is having jaundice with high-colored urine and persistently.
No, more important, child is presented at what month?
5 months.
5th month. Will you wait till 5 months to diagnose biliary atresia?
No, ma'am.
See, it is our responsibility whenever you see a child with jaundice, neonate, please ask the mother color of the urine. That simple history, if somebody has asked, they would not have missed this child. Okay, presenting at 5 months because the prognosis depends upon the age of presentation. Okay, if you just operate below 60 days, at the most 90 days, you can have bile flow at least in 70% of cases. So 5 months is little late. You cannot just sit and wait, doing all the investigation. The first system, nothing, you have to diagnose rule out biliary atresia as early as possible and give the case to a surgeon. Okay. If you think it is metabolic or intrahepatic or hepatocellular cholestasis, you can do what are the investigations you can want by giving other supporting measures. But this child, you have to rule out biliary atresia, and as you see on day 1, at 5 months of age. It is your responsibility not to miss the bus at least at this junction. Okay. Okay. Next slide. Proceed. Next slide, Ilakya. Yeah. Okay.
Dr. Rini, I just have a question for you. What are the significance of an eye exam and cardiac exam whenever you suspect cholestasis? What do you look for when you examine eyes?
Eye in metabolic conditions like galactosemia, we will have cataract, ma'am. And in Down syndrome, we can see epicanthal folds and brush field spots. In conditions like Zellweger syndrome, there may be glaucoma.
Retinitis
In
pigmentosa.
intrauterine infections, we'll have chorioretinitis. And
Allegedly syndrome will see the through the posterior embryotoxin through
Very good,
slit
very
lamp.
good. Okay. And child is not able to fix up light, rare conditions you can think. Midline defect, not able to fix up light, persistent hypoglycemia, present with shock, then it comes a panhypopituitarism. So the most common, keep the IU infections, galactosemias, Down syndrome, and sometimes hypothyroidism also you can get cataract. Okay. So cardiovascular, Shyamla said, what is the importance?
in congenital rubella syndrome, we'll have PDA, non-fatal ductus arteriosus, and in Alagili, we can have peripheral pulmonary stenosis.
Even TOF can occur, tetralocephalo, okay. So what are the anomaly you can, what sir said, no lateralization or no situs, and what other systems can be involved inside the atresia?
Lung can be involved, ma'am, and heart.
Grossly it is a cardiovascular and genitourinary with biliary atresia, okay. Okay.
Okay, go on. Next slide. There is no, you've done all the investigations under the sun.
So this is
Very exhaustive investigation. Yes, sick child. What did you do in this child? You tell me.
This child, sir. Sir, these are the investigations that we have done for this child.
You have to show the investigations. Why don't you tell him what you did and later you can show him what the values.
What all did you do out of this? What was your first, if you get a baby with cholestatic jaundice coming,
Yes.
you are the one who's receiving this child. What would you do?
So first we will admit the child first to see if there is actually persistently clay colored stools are there, or it is intermittent clay colored stools and intermittent pigmentary stools are there. Simultaneously,
How many days you will wait for that?
3 days, sir. We will just monitor the child, but simultaneously we will get the blood test also done, sir.
Nothing. A cholestatic jaundice at 150 days is beyond an emergency. Anything even 1 day beyond 60 days is an emergency. So at 150 days, you are not going to see for 3 days the stool. That's all textbook. Nothing. All that is gone. You can just see one. You show the mother, they will tell you. What I always do is to have it on my laptop, that stool color chart, and I show it to them. It takes 10 seconds for that mother to identify the color of the urine and the stool. You don't need to collect the stool and show it to you the next day and 3 days. None of that. 10 seconds, it's over. Show the color chart, show the urine chart, your diagnosis of cholestasis is made. Yes? Right. So what will you do first? First battery of tests?
So complete blood counts and liver function test, sir.
What are you looking for in the liver function test?
Sir, the total bilirubin and the fraction.
First, you have to prove that this is direct hyperbilirubinemia.
Yes, sir.
Yeah. Next, you have to look at, is it a hepatocellular or is it obstructive?
Obstructive.
If it is hepatocellular, that means your hepatocellular enzymes will be high. I'll put up a slide later and show you that. All right. Then what's the next? So you will do an LFT and counts first round. What else you will do?
So urine routine to see for a urine.
No routine. There are no routines in any. There is no routine test. You specifically tell me what you will do. Routines are for people who don't think.
Bile, urine for bile salts and bile.
For what? Baby is jaundice. So what are you going to get out of that? No.
Yes. Thyroid function. Okay.
No, I want a urine for Benedict's test. Your diagnosis of galactosemia is in front of you. So urine for Benedict's test, right? Not urine for glucose, because they do a glucose sticks. Glucose sticks will only pick up glucose in the urine. It does not pick up the other reducing substances. Do a urine for Benedict's test. What else is urgent along with the LFT?
USG abdomen, sir.
Right. You must do a prothrombin time. Please remember this. The first investigation that you take should have prothrombin time. And what will you do as soon as you take the prothrombin time?
Vitamin K.
Even if you forget everything that I have said, please remember this. You see a cholestatic jaundice, baby, please take a prothrombin time and immediately give a vitamin K. Because we have a differentiation to say correctable coagulopathy versus uncorrectable coagulopathy. What is a correctable coagulopathy? You take a prothrombin time, it's prolonged, give a vitamin K, 12 hours or 24 hours later, the prothrombin time is corrected. What does it imply?
That the child is not an acute liver cell failure.
No, it means that it's an obstructive pathology that you are dealing with. Right? Because of the inadequate bile flow, vitamin K was not being absorbed. The moment you gave vitamin K, that liver is able to extract it and produce coagulation factor. So a correctable coagulopathy is more important than just a coagulopathy. Right? So send prothrombin time, give vitamin K, repeat prothrombin time if the prothrombin time was prolonged. Emergency. Because it gives you an approach. Send a urine for Benedict's test. Right. Next investigation is?
USG abdomen, sir.
Okay, ultrasound abdomen. So what are you going to ask for in the ultrasound abdomen?
4 hours fasting, sir, and then getting a USG abdomen to look at the gallbladder, the liver echo texture, the biliary tree, and any free fluid in the abdomen at the spleen.
Okay, right. So you want to assess the liver and the spleen and to see if there is some free fluid. All right. Okay. What's the next investigation you will do?
Sir, based on it, we will plan for as the child is
first battery. Your first battery includes only this. Depending on this, you will decide. And in your LFT, please also include a GGT. Okay. Unfortunately, I don't know why GGT does not come under this LFT category. I think GGT is more important for liver rather than alkaline phosphatase. Why?
Sir, it will differentiate. If it is high, it will be reliable for obstructive pathology for the.
Both will be high. No, not that. Alkaline phosphatase is not liver specific. It's also present in the bone. Whereas gamma GT is present only in the liver. So for a liver, for us, gamma GT is far more important than alkaline phosphatase. So your first battery will include a blood counts, a urine for Benedict's, prothrombin time, vitamin K to be given immediately as soon as you have taken the blood. Don't delay even for 5 minutes. How much vitamin K will you give?
5 mg.
Huh?
5 mg. 5 milligrams.
You can't give 5 mg to a 3 kilo baby, no. Rough guide is 0.3 milligram per kg. That's a rough guide for you to remember. Okay, if you have a 10 kg child, you give 3 milligrams. Don't give too much of vitamin K. And don't go on repeating vitamin K every day. If you give a vitamin K, you are giving a big amount already. And if the prothrombin time doesn't get corrected, no point giving it next day and the day after. It only means that the pathology is significant enough for it to not work. A correctable vitamin K will correct by 12 to 24 hours. Often by 6 hours, it gets corrected. Because the liver is hungry to get some vitamin K to extract. Right? So 12 to 24 hours is when it should get corrected. If it doesn't get corrected, look at more serious causes or serious liver disease rather than just waiting for that prothrombin time and, it's a mild disease. It's not a mild disease anymore. Yes. Go on to find out what you did for this child. Tell us quickly.
Sir, these are the blood investigations.
Was it a child or a well child?
So this was a well child, sir, on arrival, not a very sick child, sir.
Right.
So these are the investigations that were done in Bangladesh, that is day 90 of life, and on arrival here, sir. The hemoglobin was.
This is the point that I made earlier, that the Bangladesh and India are no different. We are little more ahead. We are 87 days. Bangladesh is slightly behind us with 90 days. But this is the usual situation that we come across even any part of this country. It's around 3 months. Yes.
So hemoglobin was 13 to 14, sir, almost like same only, sir. There was no anemia or as such sudden bleed was not same. WBC count was also within acceptable limits, sir. It was not suggestive of a highly sepsis kind of a picture for the child. Platelets were 3 lakhs and 4 lakhs, sir. Relative thrombocytosis or thrombocytopenia was also not noted. Alkaline phosphatase was still like it was normal only, sir. It was not like excessively high. Uh, Total bilirubins and direct bilirubins, the direct fraction was high, sir. Both the times it was 3.6 the earlier time, and that this time it was 7.8, which was quite obvious of cholestasis both the times. SGOT and SGPTs, the SGPT was 42 initially, now also it was 45 only, sir. GGT initially it was 410 and now 458. Both the times it was quite high. And total proteins and albumin was relatively low this time with 3.1 on arrival here, and INR was 1.07 and 1.06. Sir.
Okay. Right. So interpret for me. Give me interpretation of this.
On arrival here, sir, that
you look at this and tell me what is your impression.
The child is having cholestasis, sir. Along with that,
okay.
conjugated bilirubin.
Listen, this is a cholestatic jaundice, confirmed. Next.
The direct bilirubin is high, and
over. It's a cholestatic jaundice. Your next conclusion.
The INR is normal, sir. So he's not having any coagulopathy.
Synthetic coagulopathy. Yes, right. Before that coagulopathy, what else? Why is the SGOT, SGPT only 60-45? What does it signify?
No transaminitis as such is seen.
Don't use this word transaminitis. Itis is inflammation. The enzymes don't get inflamed. It's a wrong terminology that is circulating around. There's nothing called transaminitis. Appendicitis means appendix is inflamed. Myocarditis means myocardium is inflamed. Transaminitis means transaminases are inflamed. They are not inflamed. Only the liver is inflamed. Hepatitis, you can say. But the transaminases are not very high, which means that this is unlikely to be a primary hepatocellular disease. So it's a cholestatic jaundice, not unlikely to be a primary hepatocellular disease. Alkaline phosphatase and GGT are high. Yes, they are high. So likely to be a obstructive pathology. INR is normal means what?
He's not having any coagulopathy as of now. So
there is no coagulopathy even without vitamin K. In other words, there is still some bile flowing through. So it's not a total obstruction. Right? If it was a biliary atresia and all that, by now I would have expected the prothrombin time to get prolonged. You look at the 4 causes of obstruction that I put up. What are the 4 I put up? Biliary atresia, bile duct paucity, congenital bile duct anomalies, and PFIs. They are the 4 causes. Biliary, so this looks like an obstructive cause. You understood my explanation? Yes, it's a cholestatic jaundice, not hepatocellular, more likely obstructive. Without a coagulopathy means that the obstruction is not total. Therefore, I would be looking at one of those 4 causes. Biliary atresia by now should have caused a coagulopathy. Biliary duct paucity can present like this. Biliary tract anomalies like choledochal cyst or calolis can be like this because there is partial bile flow. So from just this, I will narrow my differential down to 3. Biliary hypoplasia, bile duct hypoplasia, bile duct anomaly, or PFIs. These are the 3 differentials I will have after just looking through this. Are you clear? Why is this hemoglobin 14? Normally, no baby has a 14 hemoglobin at 5 months. Most of them are at physiological anemia. So has somebody transfused this baby?
No, sir. No history of transfusion as such, sir.
Very funny. Very funny. Always keep looking at the hemoglobins for this particular point of view. Very unusual to get a 14-gram hemoglobin. So you must look at what? You are going to polycythemia. But no, it's not relevant in this tale. I'm just telling you. What will I think of? a congenital cyanotic heart disease. We looked at earlier, isn't it? Sumati or Dr. Shyamala told you that you can get, yeah. So is there something to explain this high hemoglobin? Some compensatory production of hemoglobin is going on in this child. I don't know why, but it is there. Otherwise, 14 grams hemoglobin, even you and I don't have. So why should a 5-month-old baby have? They are in physiological anemia or just about recovering from that. Keep an eye on that. It doesn't look normal to me. Yes, next slide, ultrasound.
So USG abdomen was done for the child, which is shown like liver span of 8 centimeters with co-seco texture, no intrahepatic biliary dilatation. Portal vein diameter was 4.2 centimeters. Small gallbladder was visualized. No splenomegaly. Triangular cord sign was appreciated, which was 4.3 millimeters.
Okay. Right. Whenever I do an ultrasound, I not only look at the gallbladder, I also look at gallbladder function. That is what we call contractility of a gallbladder. Then a very, very, very important sign. It's far more important than everything else to rule out a biliary tract disease. Only a normal functioning gallbladder will contract after a feed. So do a 3-hour fasting ultrasound, give a feed, and see if the gallbladder is contracting. Not visualization doesn't mean anything to me. If it is contracting well, the chances of it being a biliary atresia are extremely remote. I'm not saying no, extremely remote. Triangular cord sign, I think it's a difficult sign to pick up. Radiologists seem to, 5 years ago, nobody picked up. Today, everybody seems to be picking up. I don't know how they all became experts suddenly. But I know it's not a very easy thing to pick up. HIDA scan, delayed uptake. Right, I will come to this with some slides later on. Liver biopsy?
Bile duct paucity with periportal fibrosis was seen, sir.
Right. So what is your impression on the biopsy?
Based on the biopsy findings, sir, it is more towards biliary atresia, sir.
In a biopsy, in what will you get in a biliary atresia?
Sir, the liver architecture will be preserved.
In a liver biopsy in biliary atresia, you will get bile ductular proliferation and bile plugs. I'll put up the slide later. If you have no bile duct proliferation, it is not a biliary atresia. Here, your biopsy report is looking like a bile duct paucity. Remember the second cause that I put up? Bile duct paucity. That means there is a paucity of bile ducts that have developed. You understand the difference between the two. In biliary atresia, the bile ductules formed, but they got obstructed, they got fibrosed, they got damaged during the intra. The early formation was normal, but they got damaged. Whereas and therefore, because of that, the bile ductules are proliferating. So you'll find in one biopsy bit where the portal tract is, you'll find large, instead of saying 1 or 2, you will find 6 or 7. Because of this obstruction distally, the bile ductules are proliferating. I'll put up a slide later to show you what that is. But this is looking like a bile duct paucity to me. But there is a lot of periportal fibrosis. In a bile duct paucity at 5 months, you don't get that much of periportal fibrosis. So I'm not absolutely willing to accept a diagnosis of bile duct syndromic or non-syndromic bile duct paucity at this. I will still put the possibility of a PFIC in the back of my mind. Because the ultrasound is normal, I would have ruled out all the bile duct anomalies. Choledochal cyst and Caroli's have all gone. I'm now left with bile duct paucity and PFIC. And this biopsy does not help me differentiate between these two. Yes? And when you do a biopsy for bile duct paucity, they must tell us how many number of bile ducts are there. This is not enough. I need some more information, special states. Liver biopsy is the most important investigation in a diagnosis of a cholestatic jaundice at this age. Once you know it's not metabolic, we're going to depend a lot on that liver biopsy. So they need to study that liver biopsy specimen very, very well. But even before this, we had narrowed down. You remember how I worked it out? Obstructive, we looked at 3, ultrasound ruled out 1. So now we are left with either a bile duct paucity or a progressive familial intrahepatic cholestasis. In bile duct paucity, you are not going to have jaundice and itching in the mother. Right? In which one will you get jaundice and itching in the mother?
PFIC.
In PFIC. So to me, this looks like a PFIC. Now go back to your previous slide. Your gamma GT is high. So this is a high gamma GT PFIC, if it is. Normally in PFIC type 1 and 2, you will get a high alkaline phosphatase and a low gamma GT. Whereas here your GGT is high. In infants, a GGT up to 100 is normal. Beyond the age of 1 year, the cutoff for GGT is 30. Right? So even by that, remember this. For an infant, GGT up to 100 is normal. Whereas older children and adults, it is 30. So even accounting for that 100, it's much higher. So this is a high gamma GT condition. You can get this with bile duct paucity. You can get it with biliary atresia. You can get it also with a high gamma GT PFIC. Right? So we are now tossing between a bile duct paucity and a PFIC of high gamma GT PFIC. Right? But your mother's history is what makes me think that this could be a high gamma GT PFIC. Right? Yes. So what is the next investigation I would do straight away?
Intraoperative cholangiogram.
Why? For what?
So that
Please keep surgeons away. Please keep surgeons away from this patient. Poor patient. Okay, surgeon. There are no surgeons in this audience, no. Yeah, they are dangerous people. We are far better people. Your biopsy is not showing, don't do. Only 20 years ago, the dictum was cholestatic jaundice is a surgical problem. So as soon as it came to your pediatric department, you gave it to the surgeons. And they did whatever they wanted. Today we don't. Cholestatic jaundice is our problem. It's a medical problem. Surgeons will come in only in 1/4 of cases, approximately 25%. And here this baby is already 5 months. Even if it is a biliary atresia, you operate, it will fail. So please keep the surgeons away. My next investigation will be a lipid profile. What will I expect in a biliary hyperplasia or other obstructive anomalies? Cholesterol will be high. Whereas in a PFIC, my lipid profile will be normal. So if I now do a lipid profile, I can distinguish between those two. Clear? Have you done a lipid profile or you haven't done? That's the way to distinguish between PFIC and the other obstructive disorders. Next slide. Not done? Okay. Right, fine. So what did you finally diagnose? What are you managing this child as?
This child was managed as biliary atresia only, sir. Because HIDA scan was also showed that the uptake was also delayed and there was completely no excretion into the duodenum, sir.
I think it's wrong. This cannot be a biliary atresia. This is not a biliary atresia. Right? This is not a biliary atresia. Absolutely not. This is either a progressive familial intrahepatic cholestasis, high gamma GT1, or a bile duct paucity. That biopsy will have to be looked at. You can't manage this. This is not a biliary atresia. Next slide. Do you have any more slides? Otherwise, Sumati, Dr. Shamla, you want to add something? Otherwise, I'll put up a few slides.
I think LFT, I think you have discussed in detail. So gamma GT is very, very important. Sir said low gamma GT, high gamma GT. And ultrasound, sir already mentioned nothing much. And what about the portal diameter? Is it 4.2 centimeter? I have a doubt on that. And anyway, look for other causes.
2 centimeters is huge. Must be millimeters.
Colorectal cyst. Look for any cause of colorectal cyst causing obstructive jaundice. Look for any free fluid, any malrotation, polyspenia, accessory spina, whatever it is. And HIDA, I don't think so. HIDA is going to help in this child. When you see a pale stools in front of your eye, that indicates bile is not entering the intestine. And what is the purpose of doing HIDA? HIDA we don't do when you see a persistent white or clay colored stool or yellow stool. When you have a doubt, a pale yellow stools, and are not able to differentiate, then HIDA may have a role. But even then the specificity is very low. As Sir was telling, liver biopsy, bile duct positive will not be there in biliary atresia. Again, proliferation, duct plugs, and the changes will be mainly in the periporta, portal tract expansion. So one thing that is incomplete. I think the experienced pediatric hepatologist will be able to differentiate. It's very difficult to say biliary atresia, but who is not having seen a case of biliary atresia, a pathology, whatever it is. So I have a doubt on that. I think it's better to go for a perioptical. What is the gold standard? Suppose in this case, as Sir was asking, I'm not worried. If they have done a cholangiogram and a liver biopsy, which will give much more information. to look for the patency. And ductopenia as well, one possibility is always there because gamma GT is also very high. So whenever you have a gamma GT very high, biliary atresia and ductopenic syndromes, low gamma GT and PFIC3. And low gamma GT, you have 1, 2 bile acid synthetic defect and tight junction protein and defect. There's one variety of PFIC, the latest recent advances. So the biopsy is incomplete. I'm not able to give a good conclusion. And now none of them mention about the epitocyte, whether the lobular architecture is preserved or not. If you get a lot of lobular architecture disarray, and hepatic lobules are destroyed, and they have multinucleated giant cells, you can think of intrahepatic. That is not there. And portal tract expansion is not there. The inflammation in the bile duct is not much.
No bile
So
plug.
bile duct paucity. That
No
is
bile-
one important concern which is in fear of a ductopenic syndromes.
Okay, next slide. What more do you have? That's all?
I and Dr. Sumati, the problem we had with this child is they did not have a copy of their slide from Bangladesh. The slide
Absolutely.
was interpreted in Bangladesh. So though everything seemed to us like biliary atresia, unfortunately they had not brought the slide. So that's
If you have a biliary atresia that presents by 10 to 14 days, it means almost the entire biliary tract is atretic. By 5 months, that liver would have failed. This is not a biliary atresia, full stop. This cannot be a biliary atresia. If you present biliary atresia at 14 days, that means there's nothing coming down. Stool is white at that age. How can it go on till 5 months being well? No bile coming down, not possible. So much of retention. Your liver parameters are not at all in favor of that. If you have a biliary atresia going till 5 months, there will be a coagulopathy, uncorrected, everything will be there. That liver would have failed. By 5 months, that liver would have failed. This is a very well functioning liver. Mother has had itching and jaundice. This is a PFIC. This is a high gamma GT PFIC. Right? I'll put up a few slides so that, can you close your presentation? I'll just put this up and then we can close. Okay, some of these things that I think we already discussed. In all babies with jaundice more than 2 weeks, look at whether the baby is well or sick. That's your first look. Baby is sick, it's an infection or metabolic, sepsis or metabolic. And sepsis can be intrauterine or extrauterine. Well baby, biliary atresia, bile duct paucity, PFIC, all those conditions. Skin bleed suggests coagulopathy. Abdominal examination, palpate the liver, spleen, and look for ascites. A cardiac murmur, ductal paucity, Alagille syndrome. There is ductal paucity has syndromic, which is called Alagille, and also a non-syndromic. So you can have bile duct paucity without Alagille. Fundus examination for congenital infection. And I think at a postgraduate level, all of you must comment on the fundus. I don't know why so many years we've been saying, please look at ophthalmoscopy is part of a PG examination. Look at dysmorphic features. If you have seen Alagilles, you can pick it up. Stool and urine color. Now, this is a stool chart and a urine chart. This is a normal colored stool, and this is what we call a pale stool. Right? This is the urine color chart that I use. Urine color 1 is normal. 2 could be a concentrated urine, but anything beyond 3 is an obstructive, a cholestatic jaundice. So this is what is normal. Show this chart to the mother. See, all this looks yellow. Everything is yellow. So if you ask a mother, dark yellow, deep yellow, everything is totally confusing. Right? So look at this chart. There's that's the urine one. Now, this is an even better one. This is developed in India, actually. See, this is what a urine staining of the diaper is. This is what a normal urine will stain. And this is what a cholestatic staining is. Very, very different. Please appreciate this. These are all normal stools. This is normal Indian baby stools. I'm sorry, these are pale stools, the pale stools of a cholestatic jaundice, and these are pigmented or normal stool. So you can show this baby, this is all stools of babies who had cholestatic jaundice. And these are stools of normal babies for comparison. Keep either of these two charts with you, either this or this, and this will tell you very easy to diagnose cholestatic jaundice. And this to me is the easiest to do. exactly similar to what I showed you here in this urine color chart. So either this or that is our key to early diagnosis. Lab in neonatal cholestasis, bilirubin total and direct to confirm cholestasis, ALT and AST to define hepatocellular injury, ALP and GGT denotes bile duct injury, prothrombin time tells you short-term synthetic function, albumin tells you long-term synthetic function. This baby's albumin is 3.8 if I remember right, which means that the synthetic function of this baby is totally intact. Both the short-term and long-term synthetic function is intact, which means that liver is functioning pretty well. One of the earliest functions that goes for a liver is the synthetic function, particularly the prothrombin time. Blood and urine culture for systemic or urinary sepsis, and the urine for Benedict's test again for galactosemia. Ultrasound in galactosemia, these are the 5 things I say look for. The echo texture of the liver, and ultrasoundologists will compare this with the kidney or the gallbladder. Most of the time they compare it with the kidney. So if you have a child who's also got a concomitant kidney disease, then it's very difficult for them to say whether the liver is normal or not. It's comparison. It is not an absolute value. Gallbladder shape and wall thickness, gallbladder size and contractility. Look at the biliary tree, whether there is any dilatation. Please note that in biliary atresia, the bile duct biliary tree is not dilated. If you get a dilated biliary tree, that is not biliary atresia, because only a normally developed, fully normal biliary tree can dilate. An abnormal or a scarred biliary tree cannot dilate. And you also look at a triangular cord side. Isotope scan is an often misused diagnosis. We don't now recommend an isotope scan. This is the reason why. If you have tracer in the duodenum, it means it is not a biliary atresia. But if you don't have tracer in the duodenum, it does not mean it is a biliary atresia. It could also mean that there is a hepatocellular uptake problem. The liver is badly diseased, so there is no uptake from the blood, and therefore there can be no excretion. So in our scheme of investigations, isotope scan, I don't do at all. Many people do it at as a last investigation if they have nothing else to do. But isotope scan is very low priority because it just does not help us, except this, that once you know there is a tracer there, that's the end of biliary atresia, if you have the tracer in the duodenum. Liver biopsy in biliary atresia, you look at these findings: bile duct proliferation, bile plugs in the ducts, fibrosis, and lymphocyte infiltration in the portal tract. And the sensitivity and specificity of liver biopsy in diagnosis of biliary atresia is above 90%. A good histopathologist can give you a large number of diagnoses in any cholestatic jaundice, including some of the metabolic causes can be picked up on a liver biopsy. Right. I want you to go through this. Watch this very carefully. This is the algorithm that I use. It's being played. Watch, and then we will discuss it once this is over. Okay. Now, this is the algorithm for cholestatic jaundice for all those who are watching or who are learning. Pale stool, ALP, GGT, and ALT with a bilirubin and a dark urine is your first investigations to make a diagnosis of neonatal cholestasis. First point to look, is it a sick baby or a well baby? If it is a sick baby, send a septic screen. If it is positive, you treat for sepsis. If you get an E. coli gram-negative sepsis, think of galactosemia, right? And E. coli sepsis in a newborn, always think of galactosemia. If your septic screen is negative, but the baby is sick, think of torch infections, rare, tyrosinemia, hemochromatosis, and galactosemia, because they deteriorate almost every single day. So if a baby is sick and maybe a month or 2 old, your septic screen is negative, look up metabolic first before you go after torch infection. And galactosemia is the first thing you look at because it is so easily treatable. If the baby is not sick, see if it is totally pale stool or if it's a intermittent pale stool or sometimes pigmented or partially pigmented. Do a urine culture and a thyroid function test. If your urine culture is abnormal, or TFT is abnormal, treat it as urosepsis or hypothyroidism. If those two are normal, then you do a GGT. If the GGT is low, then you make a diagnosis of PFIC type 1 and 2. If your GGT is high, then by now you would have done a fasting ultrasound. If it is abnormal, then you look at whether it is a normal liver or not. If the liver is normal, then you do a liver biopsy. The fasting ultrasound is also normal. You do a liver biopsy, metabolic, and a torch screen. If the ultrasound shows a small gallbladder, absent gallbladder, or a choledochal cyst, only then you call the surgeons. Otherwise, no surgeons. You do the liver biopsy and then wait. Is that very clear? This is a very easy algorithm. Picks up all the 6 or 7 commonest causes of cholestatic jaundice that I spoke to you about. Right. This is much of what I have said and what Dr. Sumati and all have been saying is from our consensus statement. You can read through this, and I think this is still 7 years old, but still absolutely fine. We will revise it only after another 2-3 years. It's published in the Indian Pediatrics 2014. Any questions? Yeah. Does anybody have any comments?
So 1 minute, sir. Shyamla? I think if you suspect still in the PFIC, you can do immunohistochemistry. The slide is available. Immunohistochemistry.
Yeah, so
the PFIC, if it is available.
pursued. I think we are trying to use the slide before we make further
that's what.
decisions. We want not to subject the child to another biopsy.
No, you do another biopsy. Dr. Shyamla, I think please do another biopsy.
That's what.
It's very likely that that biopsy specimen was
It's
inadequate.
not biopsy information is very, it's not very informative.
You just redo that biopsy. It's not worth the wasting.
Incomplete. It's incomplete biopsy, whatever the interpretation is not that good.
Yeah.
And for the PGs, the nutrition is also very, very important. As sir was telling, whatever be the etiology, if it's surgical, you have to go give the case to surgeon. But even after surgery, nutrition plays an important role. So supplement all the vitamins, double the dose of a recommended Me complex, and add supplementation with medium chain triglycerides, maybe it's more than 6 months. We're giving some formula, whatever it is. You have to give simil MCT oil or the natural source of your coconut oil. Why simil MCT? Because simil MCT oil does not require bile salt lipase for absorption. So directly enters the portal circulation, unlike your other triglycerides. Okay, your long chain triglycerides, whatever it is, they require bile salt activated lipase. In cholestasis, there is defective. What? Bile salt activated lipase activity is defective. So you have to give a substance that directly enters the portal circulation. So that is the main purpose of giving MCT. And if you are giving MCT, we are long term, they can go for EFA deficiency. So we always tell them to add even groundnut oil. Okay, and they are serving. And coconut oil you have to add during serving and not during cooking. That's one important practical aspects you can give. Monitor the child for growth, immunization against B or A, because on top of that, if child gets A, they can land up with acute and chronic liver cell failure. We may even lose a child. So B infection, the vaccination against B, anyway, IAP is giving all the recommendations. It has been there. Read about A vaccination and read about all about the nutrition management, your growth monitoring. And suppose a child has gone for cirrhosis, decompensation, how to manage the ascites, how to manage encephalopathy, if there is a varicose bleed, how to all those things are the complications of long-term cholestatic jaundice. Okay. Suppose if it is a genetic disorder, you have to counsel the parents because it can recur in the families. Many of the metabolic. But metabolic presented in the early, like very different. As I said, they'll be very sick. They can have altered sensorium. They can present acute liver failure. Okay, some of the metabolic uncorrectable coagulopathy. That's what he was stressing. When I give you vitamin K, it's getting corrected. It is mainly it is substratic cholestasis. If it is hepatocellular cholestasis, even after you give vitamin K, if it is not getting corrected, always keep underlying metabolic liver disease as a possibility. Okay, that's very important. So as a pediatrician, always take care of the nutrition, the growth, the vaccination, and the regular follow-up. And in counseling for the parents, if it's a metabolic liver disease or a genetic disorders. I think all have done very well. Any comments, sir? Sir has taken over nicely.
Anybody else in the fact the who have all muted and video is quiet? Dr. Pia, yeah,
Please read up the management.
I think some more. I think yeah. Can you get comments from the others? I think Dr. Ramchandran is our Dr. PRC. Yes.
Yeah, sir. Thank you, sir. I think it's an excellent guest discussion and presented by Apollo also. And as usual, Dr. John Mathai class, a lot of students like to attend, and he's giving a clear-cut message also. And now I request all judges to comment, please. Dr. Srinivasan, sir.
Others, let them do, then I will tell. Yeah, because every time, Dr. Janani, you are still there? Janani has never commented. I would like Janani to comment. Anyhow, it's a wonderful experience listening to discussion of neonatal cholestasis. I have listened to his talk earlier also, and of course, he has made it very simple and he has given very crisp points to make it as simple as possible. And I hope this video is available, and I hope those people students who missed it should see that. So that's what my comment is. I also we learned approach to cholestasis. Thank you for the simplified algorithm. Thank you.
Thank you, sir. Dr. Yeah, Dr. P. Ramachandran, sir, Dean SRMC.
Thank you. Thanks, everyone. Professor Mathai, I continue to be muted. The way you have analyzed and presented, I mean, there is hardly anything for us to say, except that really it's an enjoyable session. And probably the way the subject was understood and the experience tells us how you are able to go to the simple and very basic things and analyze. And certain things can be straight away ruled out, certain things to be considered. And Dr. Sumati also has emphasized on the very, very practical aspects. So it was thoroughly enjoyable for all of us. Now coming to the students, I really congratulate them. They presented very well. They were very clear and they were able to, whatever the questions were asked, they were able to take up the cue and answer accordingly. That is the importance in the clinical examination. They showed that. And I congratulate Dr. Shamla, who has been the mentor for them. So it was an enjoyable, thoroughly enjoyable section and a lot of good learning. Thank you so much, Professor Mathai, Sumati, and Dr. Shamla.
I forgot to mention one important comment, Dr. Mathai, and I can see the discomfiture you had that after so many 12 years still it is being missed and this thing. So the percentage has not improved at all. I hope after your talk and your efforts, I think things will become better. And I think as you mentioned, in another 3 years, we are going to again remodify the recommendations. So we hope to make it as simple as possible. And excellent. Thank you. And of course, I appreciate the students as well as Dr. Shamla and Sumati for their contributions in understanding of this particular problem. Thank you.
Dr. Rama Chandramohan, Madam, Director ICH, Stanley.
Good evening to all of you. As the PRC sir said, there's nothing really that we can add to your discussion today. It was so complete and comprehensive. And it is still a very sad thing when I see these children coming to us and without a diagnosis and coming so late. So I was just wondering whether this stool card and all that will be of any help if we are going to make it, into at least a state level. Dr. Mathai, what is your, I was wondering whether we can start it in the SNCU.
No, I had made I had actually contacted the health secretary of Tamil Nadu 4 or 5 years ago to include this in the immunization card.
Yes, that's what.
But it did not meet with much success. We were actually at that time 4 or 5 years ago looking to see if the government of India or at least the Tamil Nadu government would do that. This is about 4 years ago.
Yes.
But they said it has to go through the proper channel and In the proper channel basically means that it doesn't move. But it's
No,
a very simple thing to do.
Every primary health center should have this system.
No, that's since the
Yeah.
SNCU is all coming under Dr. Srinivasan now. I was just wondering whether we can do it as part of an NHM project.
Yes, sir.
3 years ago, Dr. Rama, I sent the card to him. He only took it up with the health secretary. Not him first.
Okay.
He was with me. I sent the card. I told them the amount of space needed, and
Yeah.
I put a lot of effort at that time.
Now the health secretary is different, so you can try again.
No, it's the same person, sir. He's the same person. Yeah, so I think we can still persevere. That's one thing. And also seeing these late HDNs, which can also be part of an NCS, when they come and they, die without management, I feel very bad about it. Anyway, you had very clear as far as the postgraduate presentation. I think it is very crystal clear for them how to go about it, and they did a good job also. Sumati, your inputs as usual, very good. So we thoroughly enjoyed the session. Shamla, you too. Thank you so much for
Sorry for intervention, and I think I will discuss with the Dr. John Mathai sir. IAP we can try to include in the IAP chart. I think we will definitely plan it. I think we will take up to
Dr. Rajendran and Dr. Mathai, Dr. Rama. It was an eye-opener for us that still, so many children are being referred late, even in our country. See, everybody has a mobile phone. So rather than get something in print, would it not be easy to send a photo of this card to parents so that they can easily, it's a great leveler, isn't it? A mobile phone. So would it not be easy to have a card on their phone, which they could, compare? It would be very easy.
How do we send the card to the phone? If it is immunization card or discharge summary, which we are giving every child who leaves an SNCU, that is that, I think almost 70% of the newborns will be covering. If we make it a part of our SNCU discharge summary, that has been what I have been telling, I've been asking Srinivasan so many times to get this as part of the schedule.
Madam, I will actually I will interact with the Dr. John Mathai sir. I think we will plan to do it through IAP, madam.
Oh.
Somewhat either we can do soft copy or we want to make it through that's immunization card, and we will also take up to a government level. We'll take it.
I think it's the best to be along with the immunization cards, because they'll be carrying the immunization card. Even the primary physician can identify early. Second, all the intramural nurseries, wherever they have, they just they can give the card. And primary health centers also, I think they can give the card. So as Srinivasan sir said.
Yeah,
So I think it should be part of the immunization card. When they come at 45 days, even then they should not miss.
That
And
is
even
what
earlier.
happened in Taiwan.
Yes.
Yeah, when
In
pulse
Taiwan,
oximetry
this
can be
is
done for
part of the-
congenital heart disease
Hello?
Yeah.
before they discharge, why not the mother be apprised of before,
Yes, sir.
this color? If you find such a color, kindly come and immediately consult.
83 SNCUs is what we have, sir. I'm sure we can cover a majority of the newborn.
Sir, in Taiwan, that stool color chart is originally from Taiwan.
Yes, sir.
Yeah, and they have increased their pickup rate enormously because it's there in the card, and the mother is told if your stool color is 1, 2, 3, 4, please report.
Yeah, that's what we must
You-
before
that's the
discharge, mother should be told.
That's
If
it.
the color becomes like that, kindly come immediately.
You only need 3 centimeters out of that immunization card.
Yes,
That's
sir.
all I need.
Yes, sir.
I asked for 3 into 2 centimeters.
We'll do it, sir.
2018.
We'll do it, sir.
Yeah, I think it's something that we can do, at least in Tamil Nadu. I think it shouldn't be difficult. Anyway, I'm meeting Srinivasan next weekend.
Yes, for the ICT. Okay, sir.
Yeah, I'll catch his ears again once more.
Yes, sir.
If he has
Please.
some-
Today Ramesh is quiet. Ramesh hasn't commented.
He's
Dr.
waiting for his
Ramesh, I will ask Dr. Ramesh sir. Yeah. Dr. Ramesh sir. Dr. Ramesh.
I think he's not there.
So even the urine color also, I think it is sensitized the mother, sir. Urine color.
Sir, can you hear me?
Yeah, please, sir.
This is one of the best presentation in recent times. Professor Mathai has done his characteristic way, very clear, crisp, and to the point. And it's very nice of him to put a few slides at the end of the presentation. because I think Dr. Ayadharan, you can request the moderators or the chairpersons to do the same in the future. So it will be a learning session. This is not, after all, an university examination. It's a teaching session. So we do students prepare for 3-4 days, and the discussion goes on for 2 hours. So this can be nicely used by experts like Professor Matai. And as he rightly pointed out, there are too much of notes. Every presentation I see, there are too much of. That is because they get a lot of time. In the university examination, if they have very detailed, elaborate history taking, all those things, 2 things are possible. Either they have already seen the case, or they have been given extra time or grace time for that. Otherwise, it's practically impossible to do the examination in 45 minutes. So it is no harm in asking detailed history and notes. But present it, edit in such a way, only the relevant no histories are mentioned. So that if you give too much of information, it kills the information. That's one thing. And this presentation, the students participated very well. The assault of questions by Professor Matai, they answered very boldly. And the interaction and inputs by the chairperson, moderators, presenters, and the judges have been excellent. I once again thank for the opportunity.
Yeah, thank you, sir. Dr. Annamalai Vijayaragan, sir. Dr. Annamalai Vijayaragan, sir.
Good evening, sir. Thank you for the opportunity. It was a very nice learning session for all of us. And I am sure that those who have attended would have benefited a lot, and they will be able to convey the crisp messages given by the chairperson, Professor John Matai, Dr. Sumati, and Dr. Shamala, to all our PG students. I think as everyone has put, we should be able to cut down the nose, so that that needs a lot of knowledge about what you are looking for, instead of trying to search for everything. So as Professor Matai has said, crisply he has put up some conditions which we have to think and then go about it. I think for every discussion, if we have like this, it will be very useful for the PGs to go about while presenting in the short time they have to present. Thank you very much, sir, for the opportunity.
Thank you, sir. Dr. Shyamala, madam, your final conclusion. Madam, unmute, madam, unmute.
Thanks to IAP TNSC, Dr. Rajendran, for giving Apollo the opportunity. And I think you kind of, as I've always been saying, it's a big service that you're doing for all postgraduates. Through lockdown time, they've still had the continuity of learning, whether they've been able to attend physical classes or not. And I think we also learn when we see these sessions. So thank you very much. And thanks to the presenters. Thanks for moderating the session very well, my friend Sumati, and Dr. Matai. Of course, you've done an excellent job. We've all learned at the end of the day. Thank you so much.
Yeah, thank you, sir, madam. And
thanks to the presenters. They've been doing a lot of work behind the scenes. They were very, very tense, I think, but Dr. Matai has allayed all their anxiety, and he's taught more than he's asked them to speak. So thank you.
Dr. John Matai, sir, you are.
Yeah. I think no. I mean, I don't know what reputation I have, but please tell people that I'm a very decent fellow, postgraduates. Sometimes I think they get very scared when they hear my name. I'm not that bad. Anyway, thank you to the presenters. I think you presented well, but I think you won't get so much time. So this really is not what the real setting is. And this is why I always think we must give them 60 minutes and then make them present. At the end of the day, please remember that all examiners have also been students once. So I know the difficulty of being a student. You understand? It's very easy to be a teacher or an examiner, right? And I became an examiner because I have seen my students or myself being treated badly. So as examiners, we have a responsibility, but please remember that we also have been students once. So we don't have to really be thorough and tense and things like that. So I think it would be nice if the students are given a reasonable time, 60 minutes or 1.5 hours to work up that case and present, and not more than that. And the examiner, the faculty should be told that, look, they got only 1 minute, 1 hour, because, so they can tailor their discussion according to that time available. Then I think it becomes better learning experience for the students. Anyway, thank you all very much for inviting me and asking me to be part of the session. As usual, when I try teach, I always learn more than what you all learn. That's why I rarely refuse, because these days I don't read unless I have a reason to read. So it helps me brush up. So thank you very much for inviting me, and good night.
Dr. Rajendran, I have a point to make.
Yeah, please, sir. Yeah.
Sir, you have to make a differentiation whether it's a teaching session or an examination case, because this looks more like a teaching session where you have access to the investigation. The moderator and the chairperson discuss the investigations also. Whereas in the university examination, it's only a clinical examination. We call it only clinical examination, oral examination, and theory examination. You have only 45 minutes. How I train my PGs is ask them the third year itself to, whenever they see a long case, they have to decide whether they are examining the patient as a short case or a long case. If it's a long case, I ask them to clock the time, stopwatch, and then keep for 45 minutes. Take the history, detailed examination, differential diagnosis, investigation, management, everything they have to write also and then see the time. Initially, as Professor Matthias said, you have to take usually more than 60 minutes. But if you do it like the university examination mode, many of the students may not have a knowledgeable person like that, Professor Mathai, teaching like this. So it is a teaching session. So you can make it out, maybe towards the end of examination time, you can make these sessions as university examination case, or you can call it as teaching sessions. So clear differentiation, because you cannot mix two, because this detailed presentation takes a lot of time. And there can be inputs by moderators, chairpersons, they can put their own slides, share their experience and discuss. So if it's an university examination, it is strictly students present like in an examination, timing is maintained and marks are allotted like that. And even you can even give the marks, judges, you may individually send it to the students, not to publicly announce it. I think this is a way of refining how to prepare our students for the university examination, because there is a lot of private medical colleges and other medical colleges where they don't have enough faculty. So this is an excellent opportunity for such people to learn from learned examiners, professors. They are sharing their experience, knowledge, and wisdom. So you must think about it, sir. Thank you.
Thank you, sir. On behalf of IAP TNSC, I thank today's chairperson, Dr. John Mathai, sir, who has spent with us almost 2 hours, and in spite of his busy schedule, and he has shared his knowledge also. We are on behalf of IAP TNSC, thank you, sir. And I thank Dr. Sumati Madam from Stanley Medical College, who has moderator and help us to for postgraduate to learn. And I thank Dr. Syamala Madam, who has make her PGs to prepare very well. Actually, they presented very nicely and discussed very well also. And because of IAP TNS, I thank Dr. Syamala Madam. I thank all the judges, Dr. Jaundice Shankar, Dr. P. Ramachandran sir, and Dr. Ramesh, and as well as Ramachandran Mohan Madam, and Dr. Srinivasan sir. And thank all the office bearers as well as students from Apollo Hospital, all the delegates as well as faculties who has participated in this discussion. Almost 640 participants took part in this today's presentation. I think I thank one and all for this wonderful opportunity. Thank you.
Thank you.
Thank you, sir.
Thank you very much.
Thank you, sir.